this phenomenon I have given one name to it, fat redistribution. Now imagine that sometime when I used to teach this as that patient can develop the obesity and all, then sometimes students used to ask that if there is high amount of cortisol, then the glucose should increase, and if the glucose is increasing, the fat should decrease. Then why there is obesity? So now you already know that there is obesity not mainly because of cortisol, but mainly because of action of which one? Insulin, right? And this is not going to increase the fat in the peripheral area, rather it is going to mainly happen in the central area, and that's why I'm using this terminology called as fat redistribution. Is this concept clear to you? So this is not the action of only cortisol, it is the action of cortisol and which one? Insulin. So this happens to you all the time. So remember, whenever you take stress, right, there is a very common thing you must have seen that as soon as the person reaches, they start work, then they start getting some truncal obesity. All of you know this thing. So whenever a person begins their work, then they start getting some tummy. And then many people say, oh, these days he's going to the office and whole day he is sitting in the chair, and that's why he's getting the this abdominal obesity. But that is not the reason. The reason is the person is have started the work. Work means what? Stress, and stress means more amount of cortisol. More amount of cortisol means there is the lipolysis in the body, and as soon as there is high amount of cortisol, very quickly there will be activity of which one? Insulin, and this insulin will put again all the glucose back in your tummy, and that's why the person starts getting the tummy. This have you seen this phenomenon or not? I mean, whenever the people begin their work, they will start getting this. Whole day he is sitting in the chair these days, and gets the tummy. Yes, like you, right? So we call it stress obesity. Clear about this thing? Okay, so now let's go further. So the first one we learned about here is going to be the fat redistribution. The second very common manifestation this patient comes to us is going to be with the hypertension. Right, patient is having hypertension. Another very big problem with this patient of the Cushing syndrome. Now, why the patient develops hypertension? There are in fact two reasons behind that. The number one reason is this cortisol, which is being secreted by the zona fasciculata. It is mainly having the glucocorticoid function, but it also has some amount of mineralocorticoid function. Right? It has some ability to do the mineralocorticoid function. It means it will go to your kidney and it is going to cause more and more sodium reabsorption. And when there is more sodium reabsorption, the blood volume, the plasma volume of your body is going to be increased or decreased? Increased, more reabsorption of the water, and that's why the patient is going to develop the high blood pressure. So keep in mind, the first cause of the hypertension here is increase in sodium reabsorption. And the second cause of the hypertension in case of the Cushing syndrome is that this patient, when they have high amount of cortisol in the body, the cortisol increases. Try to understand this phenomena. Many books don't talk about this phenomena. The cortisol is going to increase the peripheral blood vessel sensitivity toward the catecholamines. All of you know catecholamine? So you already know that in your adrenal gland, the medulla of the adrenal gland is the one that produces the epinephrine and norepinephrine. We simply call them catecholamines. So when there is high amount of cortisol, this cortisol will go to your peripheral blood vessels and it is going to increase the sensitivity of the catecholamine. Sensitivity to the catecholamine. So you tell me, if there is high amount of cortisol, then the peripheral blood vessel will be responding more to the catecholamine or less? More, and the peripheral blood vessels are going through constriction, and the peripheral resistance will increase, and patient is going to have the high blood pressure. So this is a very important phenomena, and you need to write this very clearly in your paper. You need to understand this phenomena. So it is going to increase the sensitivity toward which hormone? Catecholamines. Alright, so this is the second manifestation of the patient with the Cushing syndrome is going to be hypertension. Okay, now let's go further. This patient, when they are having high amount of cortisol in the body, if it is female can develop the hirsutism, female can even develop the amenorrhea, and if it is male, then male can even develop which disease? Erectile dysfunction. So all of you tell me the reason behind that. What is the cause? So if there is high amount of cortisol, there will be the negative feedback to which one? Gonadotropic stimulating hormone. So don't forget, high amount of cortisol is not only going to give the negative feedback to SCTS, it is also going to give the negative feedback to which one? gonadotropic stimulating hormone, and due to which the female can develop the amenorrhea, can develop the hirsutism, as well as the male can develop the erectile dysfunction. Is this thing clear to you? So because you can imagine that why it is happening, because of the cortisol, it is causing negative feedback to gonadotropic stimulating hormone. Okay, now after learning these three very common causes, the another very important thing that the patient, they are going to come to us, we have to understand, is that, all of you tell me, the patient is going to have more glucose in the body or less glucose in the body? More glucose. So this patient may have all the sign and symptom and the manifestation of hyperglycemia. So in the last class we discussed in very much detail about the diabetes. So whatever we learned, the sign and symptom of the hyperglycemia, all of them they can happen even here. So hyperglycemia is going to be very commonly seen. Now if somebody asks you why hyperglycemia, so two things are there. Hyperglycemia because high amount of cortisol increasing the glucose in the blood. At the same time, hyperglycemia is also due to the high amount of cortisol will also make your tissues resistant to the insulin. That's why the name has been given which one? Anti-insulin. So whenever your body have high amount of cortisol, your body will make your tissues resistant to the insulin, and the insulin cannot work to put the glucose back in the tissues, and that's why we have given the name anti-insulin. Clear about this thing? So this is the cause of hyperglycemia. And what are the manifestations of hyperglycemia? Tell me the three very important features of hyperglycemia. Polyuria, polydipsia, polyphagia with weight loss, right? So all these manifestations are going to happen. You tell me if somebody is having hyperglycemia for a long time, the wound healing will be faster or slower? Slower. So all this feature is there. I'm not going to describe about this phenomena. You already understand this thing. Okay, now another very important thing you don't forget, that if the patient is having high amount of cortisol for a long time, the patient are also going to be very vulnerable toward fractures, right? So patient may develop the fractures, or patient can even develop the osteoporosis. So fracture and osteoporosis will be common in this patient. Another very common manifestation of this disease is going to be that this person are going to have few features in the skin. You must remember, one feature in the skin you already know. In the trunk, in the abdomen, there is going to be one specific kind of striae. What is that? Purple striae. Another very important one, this patient will develop the skin thinning. The skin will become very, very thin. Not only thin, but the skin will also be very, there will be lots of bruises, easily bruisable. So any small kind of injury can lead to the bruising formation. So the patient is going to have the bruisable, the patient will develop the phenomena of easy bruising, right? And this patient, they are going to have even some of the other manifestation of the skin will also happen in their the skin. For example, the patient is also going to have decreased ability to wound healing. The striae can even happen in other places. So main things are here to remember: skin thinning and the easy bruising, and another is decreased wound healing. So these patient can happen to the patient. These features can happen to the patient. Okay, now let's go further here. Another very important feature that can happen to this patient, you can imagine there is high amount of cortisol in the body, right? And you already know whenever there is high amount of cortisol in the body, it is going to decrease. If there is lots of steroid given to you, if we give to the steroid to a person, it is inflammatory or anti-inflammatory? Anti-inflammatory, right? So steroid is always going to decrease your immunity. And if there is naturally high amount of steroid in your body, your immunity is going to be strong or weak? Weak, right? So patient is also going to have the immunosuppression. So all those features of the immunosuppression can be also seen here. So patient may have the immunosuppression problems. Okay. And one more thing you keep in mind, that the cortisol activity is also seen in the brain, right? So if somebody is having high amount of cortisol, then the patient may also come to you with some psychological problems. For example, the patient may have the poor concentration, and sometimes the patient may even go to the psychosis in a very severe form. Even the patient can reach to the psychosis. So these are the 8 common features of the Cushing syndrome. All of us, let's try to understand one by one. What is the most common feature of the Cushing syndrome? Fat redistribution. What is there in the face? Moon faces, in the neck, buffalo hump, and in the truncal obesity with which striae? Purple striae. Okay, then what is the second feature of this disease? Hypertension. Tell me the two reasons for hypertension. What is the first reason? Increased sodium reabsorption. What is the second one? Patient is having increased sensitivity to which hormone? Catecholamine. Tell me the third cause of this disease, third manifestation of this disease. Yes, so patient may develop the hirsutism, amenorrhea in case of the female, and male can even develop the erectile dysfunction. So is this concept clear to you or not? Why the patient have got this hirsutism and all problem? Is this clear to you? Okay. Then what is the fourth manifestation of this disease? Hyperglycemia. So all the manifestations of hyperglycemia you can put here. And then what is the next one? Fractures and the osteoporosis. What is the next one? Skin thinning, easily bruising, and the decreased wound healing ability. And then what is the next one? Immunosuppression. And the next one is poor concentration. All of you got an idea? Okay, now let's imagine when this patient will come to you, if you are going to do some lab test, what will be the common things you are going to find in the lab test? What are the common things we find in the lab test? So you already know. The number one and very important, the glucose is going to be more or less? More. So patient may develop the hyperglycemia, right? You tell me, the patient is going to have hyperglycemia and patient is also having the fat redistribution. So even the LDL is going to be very, very high, right? You tell me, the sodium in the body is going to be increased or decreased? Sodium in the body is going to be increased or decreased? Increased, more sodium will be reabsorbed, so there will be hypernatremia. Potassium in the body will be increased or decreased? Potassium decreased, right, because of the mineralocorticoid activity. So patient is going to have the hypokalemia, and you already know that if the patient is having hypokalemia, then patient may develop the metabolic alkalosis, right? Not always, but as a general rule, you always keep in mind the potassium and the acidosis alkalosis always are in same direction. If patient gets the hyperkalemia, patient gets the acidosis. If patient gets the hypokalemia, patient gets the alkalosis. Generally it happens, not always, it's not a rule, but just for your understanding, if the problem is in the adrenal gland, then it happens this way. So high potassium is going to cause the acidosis and low potassium is going to cause alkalosis. Clear what you think? Okay. So these are the features that we can understand very easily. There is going to be hyperglycemia, there is going to be the increased LDL, there is going to be the hypernatremia, hypokalemia and metabolic alkalosis. But the one that I am very much concerned here is this one. In this patient, we are going to find very, very high amount of leukocytes. Patient will develop the leukocytosis. Now we need to understand this mechanism, that why the patient develops the leukocytosis. By the way, in this disease, is the patient having any kind of infection? No, patient is not even having the fever. Now the question is that why the patient is having leukocytosis. Try to understand this thing. Whenever your bone marrow produces the WBCs, these WBCs, they start flowing in your circulation, and this WBC, they go in the lymph nodes and they get, we have already discussed this thing in your hematology, that these lymphocytes, they go and get stored even in the lymph nodes, right? And 50% of your WBCs, when they are formed from the bone marrow, 50% of the WBC, they get stick with the wall of your blood vessel. Try to imagine this thing. And they are, you can imagine them like sometime you must have seen when you go outside, the policeman, they are in the car and they are just waiting, right? So these WBCs are same. They are just waiting in the blood vessel. And whenever a person gets infection, you don't have time to get more and more WBC coming from the bone marrow. Rather, you can simply recruit these WBCs from the blood vessel wall, right? So what happens if a person is having high amount of stress due to the high amount of cortisol in the body, right? Then these WBCs, which are generally, and don't forget, this WBC is not less in amount. If your bone marrow produces 100, then how many of them they are going to be in this phenomena? 50%, not just less. So 50% of them, they are going to be situated in the blood vessel wall like this. And whenever your body will get high amount of cortisol, then your body will go through the stress and body will feel that now there is some kind of infection going on. And all these WBCs now will be recruited in your circulation. So now suddenly there is going to be increase in what? The number of WBCs. Is this concept clear to you? So all of you try to revise this thing. Normally whenever your bone marrow produces the WBCs, 50% of them, what is their job? To get and lie within the blood vessel walls. to be ready. Whenever the infection will come, they will be recruited in the circulation and they will start fighting with the infection. But this thing happens in control by the cortisol, and cortisol is the stress hormone. So whenever you get infection, your cortisol increases, and this cortisol goes and recruits this WBC from the wall in the circulation, and that's how the WBC is going to be increased. Is this concept clear to all of you or not? So never forget that leukocytosis is going to happen in this patient, but he is not having any kind of infection, right? So this is the one very common thing. So keep in mind, this WBCs, they are the marginalized. We call this phenomena as that whenever the bone marrow produces the WBCs, this WBC gets marginalized, 50% of them, and whenever there is a high amount of cortisol, this WBC from the margin will come back to the circulation, and we call it demarginalization, right? So now if somebody asks you why there is leukocytosis, the answer is very simple: demarginalization of the WBC from the blood vessel wall due to high amount of stress, that is the cortisol. So demarginalization of the WBC is going to cause the leukocytosis. Clear about this thing? Okay, yes?
So there is leukocytosis, then why there is a chance of infection?
Why the chance of?
Infection.
Okay, so keep in your mind, it's not only for hair. Whenever we think about any kind of steroid, all the steroids in our body are going to be anti-inflammatory, right? Anti-inflammatory. And when these WBCs, they are going to be recruited in the circulation, until and unless this WBC go through the process of inflammation, then does it help in your immunity? Only this WBC, having lots of WBC in your blood, is it going to increase your immunity? No. This WBC requires to show the function by release of some chemicals like the interleukins. All of us we know this thing, isn't it? So you know that inflammation are having two pathways. So if the inflammatory pathway is not started by these WBCs, then all the WBC is high, but can this WBC help in your protection? No, you don't think that this WBC will be helping you without activating the inflammation. That's not going to happen. Few of them, they may. Some of the WBCs, they may do the work, but the main function is by causing the inflammation. So we know that inflammation is protective mechanism, but when it goes exaggerated, it can sometimes even cause the trouble. Clear? So why there is immunosuppression? Because it is going to decrease the inflammation, but WBC is high. But this WBC is not high because of the bone marrow. This WBC is high because of which process? Demarginalization. So it means if this WBC, after some time when the cortisol level is okay, they will find out okay there is no infection, then again they are going to come back to the normal level. Clear what I'm saying? So these are the common lab values of the Cushing syndrome. Okay, so can I erase this thing? Okay, so now let's go for the next part of our Cushing syndrome, and this part is the most important and a little confusing. So let me see how long will you take to understand this thing. To diagnose the Cushing syndrome, and moreover diagnosing, the main thing is to localize the Cushing syndrome, that which kind of Cushing syndrome the patient is having. So we are now talking about the diagnosis of the Cushing syndrome, right? So let's talk about diagnosis of Cushing syndrome. Diagnosis. Okay. Keep in mind, if somebody asks you what is the best initial test, what is the best initial test to diagnose? So in the exam they are going to use this kind of sentences. The best initial test to diagnose the Cushing syndrome. I am not talking about the type of Cushing syndrome, I am just telling you right now the Cushing syndrome is present or not. Right? So the best one, there are three very common methods, but the best one out of all is going to be 24-hour urinary cortisol level. Right? 24-hour urinary cortisol level. So we are going to check the urinary free cortisol in the urine for 24 hours.